Hi, in this screencast we're going to discuss an approach to congenital heart disease. Now, congenital heart disease is a really complicated and very big topic. You need to know a lot of different things about the heart in order to grasp it. You have to know heart anatomy, have some background in embryology, understand valvular disease even, and understand chamber hypertrophy enlargement, and understand shunts. So you have to understand a lot of different things in order to understand congenital heart disease. It can make it challenging to digest, and so that's why I wanted to kind of lay out an approach to kind of organizing your thinking about it and also go over some tricky topics within it. So we'll start with discussing congenital heart disease classification. I know Dr. Barati and Dr. DeFreitas discussed that briefly, but I just thought I'd lay out kind of how I think about classifying congenital heart disease, and then go over three concepts that Dr. DeFreitas talked about. Concept one being Eisenmenger's physiology. Concept two, the idea that the level of the shunt drives what chambers enlarge or hypertrophy. The third concept is the concept of ductal dependent lesions. And then finally, we'll recap with a summary of congenital heart disease presentations. Cyanosis isn't the only presentation you can have with congenital heart disease, and Dr. DeFreitas went over several of them. So let's start with the classification of congenital heart disease. There are a lot of ways to slice and dice this, but I think the most straightforward way is to first think about congenital heart disease in terms of acyanotic lesions, which is shown in red because you get red or good perfusion to the body, and cyanotic lesions, which is shown in blue because you have mixing of desaturated venous blood into the systemic circulation, leading to a cyanotic lesion. Now, laid out here are some subclassifications for both acyanotic lesions and cyanotic lesions. You can see that acyanotic lesions, one subclassification are lesions that lead to left to right shunting. So since you have shunting of red blood to the right or sort of blue blood side of the circulation, you don't get any desaturation when you get to the systemic circulation. So that's why the word shunting is shown here in red. You get, despite the shunt, you get normal oxygenation in the systemic circulation. The other subclassification of acyanotic lesions are lesions that are obstructive or are a stenosis, some sort of valvular stenosis, for example. When thinking about cyanotic lesions, there always has to be right to left shunting, right? Because otherwise, how do you get the cyanosis? You always have to have desaturated venous blood going to the systemic circulation, leading to shunting, which is shown here in purple, because it's a mixture of the blue desaturated venous blood and the red systemic blood. Now we're going to fill in all the different lesions that you've learned about under these subcategorizations, and let's just go through them briefly here. I'll leave it up to you to learn the individual lesions, but I at least want you to understand why these lesions go into these categories. So atrial septal defect and ventricular septal defect, because left atrial pressures are typically higher than right atrial pressures, you get left to right shunting. Patent ductus arteriosus, for the same reason, the connection between the aorta and the pulmonary artery. The aortic pressure is higher than the pulmonary artery pressure, so you get, again, left to right shunting. Partial anomalous pulmonary venous return. You have some pulmonary veins coming into the right atrium, and that, again, is a form of left to right shunting because you have the nice and saturated pulmonary venous blood returning to the desaturated right atrium. And aortopulmonary window, again, a connection between the aorta and the pulmonary artery. So those are the types of left to right shunt to know about. In terms of stenosis, some of the forms of stenosis discussed were congenital aortic stenosis, interrupted aortic arch, coarctation of the aorta, pulmonic stenosis, and a really important congenital heart lesion that wasn't discussed necessarily in the congenital lectures, but in the valvular lectures, because the presentation of bicuspid aortic valve typically occurs later in adulthood, but actually is one of the most common forms of congenital heart disease. So these are the acyanotic lesions, which you can broadly group into left to right shunting and stenotic type lesions. The cyanotic lesions are the ones that give you right to left shunting, and broadly speaking, you could think of these lesions as lesions that give you sort of a bad connection, a reverse connection, or a missing connection. Now, the important concept to grasp here is that regardless of the lesion, whether or not the lesion has a shunt built into the description of it or not, there must be a shunt in order for the child to survive. So for example, transposition of the great arteries. If you have a switch between your pulmonary artery and your aorta, then what happens is there would be complete disconnect between the pulmonary and the systemic circulations. They would be completely independent. The only way a child with that can survive is for there to be a shunt in order to allow mixing of blood. So, for example, transposition of the great arteries often depends on a patent ductus arteriosus being present in order for the child to survive, and that will drive a right to left type shunt, which will lead to cyanosis. So in terms of bad connections, you should know about tetralogy of Fallot, something that may show up on boards, but we're not going to discuss here because we didn't cover it in lectures, truncus arteriosus. Reverse connections, transposition of the great arteries, and sort of missing connections, tricuspid atresia, pulmonary atresia, hypoplastic left heart syndrome, and total anomalous pulmonary venous return, where all the venous return from the pulmonary veins goes to the right atrium rather than the left atrium. So I think this is a decent broad sort of classification of congenital heart disease. And I just wanted to go through a couple of things to highlight it to help you kind of pick out what's salient, because this is a lot of different disorders. So shown here in bold and red are the most common types of congenital heart disease. So atrial septal defect, and we want you to know about the primum and secundum types of atrial septal defect, although there are two others. Ventricular septal defect, patent ductus arteriosus, and bicuspid aortic valve. So these are the most common congenital heart disease manifestations. So here's another one, another way to kind of keep these separate in your mind. And this is probably one of the more useful mnemonics in all of medicine, because all the cyanotic lesions, 5 of them at least, you can see here in blue, all start with the letter T. So there you go by the 5 terrible T's: tetralogy of Fallot, truncus arteriosus, transposition of the great arteries, tricuspid atresia, total anomalous pulmonary venous return. And you'll notice over here, none of them begin with T. So I think this is a really easy way to start to at least keep the cyanotic lesions separate in your mind. And I guess maybe you can add on a couple letters for pulmonary atresia and hypoplastic left heart syndrome. So terrible T's give you a clue as to the fact that it's a cyanotic lesion you're dealing with. And I just wanted to highlight one thing because it can be confusing, but I think thinking through it really helps you understand congenital heart disease, and that's the case of pulmonary venous return. If you have partial anomalous pulmonary venous return, then that's a type of left to right shunting, because you're sending left-sided saturated blood to the right side. So that's left to right shunting. Total anomalous pulmonary venous return ends up being a form of right to left shunting, because you're sending all the blood from the left side to the right side, meaning that you are creating a total disconnect in circulation. And the only way that you can overcome that is by sending blood from the right side back to the left side in order to support systemic circulation. And so you need another shunt, maybe an ASD or a PDA, in order to support circulation. So that's why total anomalous pulmonary venous return ends up being a cyanotic lesion, whereas partial anomalous pulmonary venous return is an acyanotic lesion. So those are just some ways to think about and start to break apart the different congenital heart disease defects that you learned about in lecture. I think that might help you kind of group these into different categories. So I just wanted to next go through a couple of the difficult concepts, and I think one of the more important ones to understand is Eisenmenger's physiology, because Eisenmenger's physiology can turn any left to right type of shunt into a right to left type of shunt. And so that's really important, because this can often lead to cyanosis presenting late in life or later in life. So here's a little drawing of the heart adapted from diagrams in Lilly. So vena cava, right atrium, right ventricle, pulmonary artery, and pulmonary veins, left atrium, left ventricle, aorta. The right side of the heart is in blue because it's desaturated blood. The left side of the heart is in red because it's saturated blood. So I think this is a kind of a useful diagram. It looks a little bit like 2 Decepticons next to each other. It's useful because it's easy to draw, and most of the abnormalities in congenital heart disease, you can use this diagram to kind of work through in your head to figure out which chambers are enlarging, etc. There are a couple where it doesn't work for example, tetralogy of Fallot, the anatomy is too distorted. But we're going to use this to kind of work through Eisenmenger's physiology. So the first thing that happens in Eisenmenger's physiology, let's just say, is that the individual has some type of large left to right shunt. So if it's a teeny tiny left to right shunt, you're not going to get enough overload on the right side of the circulation in order to drive the physiology. You really need a large shunt in order to get Eisenmenger's physiology to manifest. So let's give this heart a ventricular septal defect. So I've just erased part of the septum and written ventricular septal defect across here. So a ventricular septal defect, because the left-sided pressure is higher than the right-sided pressure, will lead to saturated blood mixing in to the right side of the heart, and so that's this sort of purple stream here going into the pulmonary artery. So this is going to give you blood that is more saturated than sort of the normal venous blood. So instead of a saturation of, let's say, 75% coming from the vena cava, maybe the saturation will be 85% or so. So you have a large left to right shunt, and what that does is you have a lot of extra blood flow through the lungs, and that eventually leads to damage to the pulmonary arteries and arterioles, and that damage causes them to have an increased pulmonary vascular resistance. So I've depicted that by sort of a narrowing on the nozzle here. And so there's increased pulmonary vascular resistance, and what that leads to is increase in right ventricular pressures. So the right ventricle has to hypertrophy, and it has to drive up higher pressures in order to maintain blood flow across the pulmonary bed. What can happen eventually is that the right-sided pressures exceed the left-sided pressures. And if that happens, then you get actually a reversal of the shunt direction. That is, the previously left to right shunt now becomes a right to left shunt, and that can give you cyanosis. So it's important to recognize that any large left to right shunt can lead to Eisenmenger's physiology. And so here again are just depicted some of the left to right type shunts, and if any of these are large enough, you can eventually get Eisenmenger's. So the second tricky concept I kind of want to walk through was that the shunt level drives the changes in chamber size. And I think that's really kind of tricky to understand, because what we're talking about is left to right shunts typically, and how either right or left-sided structures can get enlarged. And I think thinking through this is worth doing. So I think one of the reasons it's confusing, at least for me, is that we know that left to right shunts, by definition, have a QPQS greater than 1, right? What that is basically saying is the flow through the pulmonary circuit is higher than the flow through the systemic circuit, because the right side is sort of sending the normal amount of blood through as well as the shunted blood around. But then what's tricky is, how do left-sided structures get enlarged with a left to right shunt? You would think only right-sided structures, since they have the higher QPQS, are susceptible. But the reason is because depending on the level of the shunt, and we'll go through examples of this, either left or right-sided structures may have increased amount of flow. That is to say, even though the QPQS is greater than 1, what that really just tells you is that the pulmonary flow through sort of the pulmonary vasculature is higher than the systemic flow through the systemic vasculature. But it doesn't tell you anything about intracardiac flow. It doesn't tell you anything about whether, for example, it's the left ventricle or the right ventricle that is experiencing increased flow. And what that depends on is the level of the shunt. So you have to think a little bit more granularly anatomically in order to understand that. So we'll go through 3 examples, but first I just wanted to remind you of these guys and the equation of QPQS. You should take a moment just to convince yourself that this equation works out, and that if you get a right to left shunt, you would get increased saturations of the pulmonary artery, and that would lead to a QPQS greater than 1, indicating higher pulmonary flow. And if you got a left to right shunt, leading to decreased saturations in the aorta, you would get a QPQS less than 1. Okay, so let's walk through atrial septal defect using our diagram again. And atrial septal defect is a defect in the atrium, and again, there are two types that we want you to know about, the primum and secundum type atrial septal defect. And it starts at the level of the atrium, and so you get left to right shunting through the right atrium, right ventricle, and pulmonary artery. And all these structures actually experience extra load. It turns out to be a volume overload because it's a preload, or it's low pressure blood filling the chambers, so that we consider that a volume overload. And these structures dilate. And so it's important to note that the left ventricle is essentially unaffected. Note that the shunt is coming in through the pulmonary veins, through the left atrium, into the right atrium and right ventricle. But the left ventricle is sort of unloaded. That is to say, the shunt has already sort of shunted off before the left ventricle experiences extra volume load. So the left ventricle isn't affected in this case. Okay, now let's look at ventricular septal defect. And so this is a shunt at the level of the ventricles. And Dr. DeFreitas discussed how the left ventricle is often the ventricle that's propelling the blood right into the pulmonary artery. So in effect, the right ventricle can be spared of the volume overload. Some sources will also say that the right ventricle is experiencing a volume overload, so I guess it can be variable, but the important thing is that there's extra blood flow through the pulmonary artery. So what that means, and this is really critical, is that you have increased return of blood, venous return, through the pulmonary veins, right? Because the blood, all the blood that gets to the lungs through the pulmonary artery is going to end up in the pulmonary veins. So there's increased venous return to the left side of the heart because of the extra blood going through the pulmonary artery circuit. So that means you have increased return of blood and increased volume in the left atrium and the left ventricle. And the left atrium and left ventricle can therefore enlarge. And depending on whether the right ventricle is also experiencing a volume load from this shunt, that is to say, is the right ventricle also doing work to propel this blood out of it into the pulmonary artery, the right ventricle can potentially enlarge too. So that's ventricular septal defect. So patent ductus arteriosus is a little more straightforward than that. And basically, you can see from this diagram here that the shunting is occurring after the aorta. The left ventricle is clearly propelling the blood out of the aorta, both through the ductus arteriosus that's patent and through the normal circuit to the systemic circulation. Again, just like ventricular septal defect, all that blood that ended up extra in the pulmonary artery is going to get returned back to through the pulmonary veins to the left atrium and the left ventricle. So these chambers can also enlarge, and that's why with patent ductus arteriosus, you get a left atrial and left ventricular enlargement. So it's important to see, I think that different chambers dilate depending on the level of the shunt, ASD, VSD, PDA. So, but thinking through that anatomically, I think you can kind of understand why. So the third concept I want to discuss is ductal dependence. And ductal dependence is important because we have drugs, prostaglandins, in order to maintain the duct open if someone has a ductal dependent lesion. And Dr. DeFreitas made the point that a patent ductus arteriosus can support either a left to right shunt or a right to left shunt. And I thought we would just walk through that a little bit. So again, here's that Decepticon drawing of the heart with the ductus arteriosus. And here's a blow up of it. So here's the pulmonary artery on the left, the ductus arteriosus, and the aorta on the right. And let's just start with a left to right type of support. So let's say that this patient has pulmonary atresia, the pulmonary artery is atretic, and there isn't much blood flow through it. So the child, when it's born, has the ductus arteriosus patent, and the only way blood is really getting to the lungs in order to get oxygenated is through the ductus arteriosus. There's very little blood flow, if any, through the pulmonary artery immediately after the pulmonary valve because the pulmonary valve is atretic. So you have left to right support, supporting the circulation. And then let's say the shunt collapses. Then what happens is you get collapse of pulmonary blood flow. There isn't sufficient blood going through the pulmonary circulation. And then what happens is there's incomplete oxygenation of the blood leading to cyanosis. So now let's discuss right to left support. What if someone has, for example, hypoplastic left heart syndrome? So this is an example of where there's very little, if any, blood flow out of the aorta, the aortic valve to the aorta. So the only way the child can survive is by having a synodic mixture of desaturated blood into the systemic circulation. And let's say the shunt collapses. Then what happens is you have diminished aortic flow, and that can manifest as shock. So a ductal dependent lesion can either be a right to left shunt or a left to right shunt, and upon collapse it can either manifest as cyanosis and hypoxia, or it can manifest as shock. So I just wanted to, on one slide, kind of recap some of the congenital heart disease presentations that Dr. DeFreitas discussed, because cyanosis is the easiest presentation to understand because it's built into the classification symptoms system. But I think it's important to understand that there are many clinical presentations of congenital heart disease, and it depends on kind of the lesions and how severe the disease is, whether or not the presentation will be neonatal or childhood or adult. So these are just listed some of the things that you should be familiar with that Dr. DeFreitas discussed: pulmonary overcirculation, what that syndrome looks like, Eisenmenger's physiology, cyanosis, and also the long-term sequelae of cyanosis. I think pressure or volume overload of the left or right ventricle, it's important to note that that alone can lead to a lot of different diseases like systolic dysfunction, diastolic dysfunction. Chamber enlargement from the pressure or volume overload can lead to dilatation of the annulus of the mitral or tricuspid valves, leading to valvular incompetence and arrhythmia. And you can see that this is sort of a microcosm of adult CHF, because you can get a lot of the same manifestations with, for example, long-standing hypertension. Vessel hypoplasia due to poor flow is another clinical presentation of congenital heart disease, and aneurysmal dilatation after a stenotic lesion is kind of a classic association too, and these are adapted from Dr. DeFreitas' slides. So that's all I wanted to discuss. I hope I was able to kind of give you a framework for thinking about congenital heart disease, and also go through some tricky concepts, and kind of, I think now when you go through the different congenital heart lesions, you can classify them and begin to understand how the pathophysiology is linked to the anatomic abnormality. Thanks very much.